There were a number of important historical trends that brought us to the TAILORx results being presented and published today. First of all, adjuvant systemic therapy for early stage breast cancer has been a clear public health success, lowering the rates of recurrence and death from breast cancer in all parts of the world where it is being used. At the same time, we have begun to evolve scientific understanding in some areas that allow us to select patients with greater precision. And I want to be very clear. Estrogen receptor is a good prognostic factor, but it allows us, more importantly, to select those patients who might benefit from endocrine therapy in the adjuvant setting. HER2, that's a poor prognostic factor, but it allows us to select those patients who benefit from anti-HER2 therapy, so it's a positive predictive factor. I'm emphasizing this because that brings us to chemotherapy, the third standard component of adjuvant therapy. Up until now, we haven't had any direct way to select those patients whose tumors would be more or less sensitive. And what we relied on instead was the observations from the Early Breast Cancer Trial Assigning Collaborative group that demonstrated absolute risk reductions that varied in proportion to the underlying risk. But these are described as constant relative risk reductions. And so that meant that the higher the risk of recurrence, the greater the benefit of chemotherapy, a kind of one-size-fits-all approach. In the face of very good outcomes for early-stage breast cancer, the known toxicities and inconvenience and expenses of chemotherapy, there's been a push to figure out who really needs chemotherapy and who doesn't. And let me circle back for just a moment. We don't throw trastuzumab or endocrine therapy at a patient solely because they have high risk. We use them when they have sufficient risk to justify treatment and they have the target. So the Oncotype DX was the first attempt to do this at the genomic level using mRNA activity detected in paraffin-embedded material. That's a technical advantage which allows them to use old stored material and not worry about how it was obtained or how recently it was stored. Using that approach, 16 genes are compared to 5 reference genes, hence the 21 gene recurrence score. And when initially presented in 2004, published in the New England Journal, it was another prognostic factor. High scores, worse outcome. In a subset of patients, all of whom had estrogen receptor positive, node negative disease, all of whom were treated with tamoxifen. So many of us collectively shrug our shoulders and say, here's an expensive new prognostic test, so what? Well, they went back retrospectively, looked at 2 prospective randomized trials testing chemotherapy added to endocrine therapy. One was in node negative disease, B20, one was in node positive disease, that's the SWOG study, 8814. And they came to the same conclusions. Higher scores were associated with a chemotherapy benefit, low scores were not. Still, we need prospective validation. That brings us to today. The TAILORx was the first prospective trial to test this in a rigorous way. These patients were tested, and then if they had an intermediate score, 11 to 25, which it's important to emphasize is lower than the commercial test result thresholds, but in that range they were assigned to standard treatment with chemotherapy or experimental, if you will, treatment where the chemotherapy was omitted. High scores were assigned to chemotherapy and endocrine therapy. Low scores, the part we're hearing about today, just endocrine therapy. And so many will at this point ask, why is the non-randomized low-risk cohort presented today important? It's important because there were over 1,600 patients in this group, and with prospective observation, 5 years of follow-up, there were a very small number of recurrences. In fact, the 5-year distant disease-free survival exceeds 99%. That's a good enough number from a prognostic point of view that one can't speculate that there'd be any meaningful benefit for chemotherapy. So this is the first real validation that a clinician could use that test, opt out of recommending chemotherapy, and feel safe and comfortable in doing so. It immediately raises some possible concerns, however, as all good results do. For example, when we do hear about the randomized cohort, if we discover that patients with scores of 11 to 25 benefit from chemotherapy, we're going to have a little bit of a disconnect between this threshold of 11 and the current commercial threshold of 18. Should those patients in that low intermediate zone be treated with chemotherapy or not? We don't know today. At the same time, of course, if the randomization for chemotherapy reveals no benefit, then this question will become moot. So to summarize why this is important, this is the first prospective long-term evidence that the Oncotype DX 21 gene recurrence score can be used to select a very low risk of cohort of patients who do not need to add chemotherapy to their standard endocrine treatment.